Good afternoon, my dear colleagues, residents, and fellows. Thank you for joining us today in our weekly grand round to discuss some new approaches to the management of corneal hydrops in keratoconus patients. I highly appreciate the effort and the time for you to come here with us. Allow me to introduce our distinguished speaker, Dr. Halah bin Helayel, a remarkable member of our cornea service here at KKISH and a valuable addition since she has joined us. Dr. Hala is a Dr. Hala is a very energetic and innovative clinician, as well as a smart and meticulous researcher, in addition to being a talented surgeon. She has always been very motivated to adopt new techniques and technologies. So without overdue, let me leave the floor for her to tell you more through her presentation. تفضلي حالة.
Today we'll talk about the corneal hydrops as a rethinking treatment. So acute hydrop is the devastating complications of keratoconus and other ectatic disorder. It started as a sudden corneal edema that results from a tear in the descemet membrane, which results in decreased vision, photosensitivity, redness, and pain. Many risk factors are implicated, such as Down syndrome, atopy, vernal keratoconjunctivitis, eye rubbing, and an aerial age of keratoconus onset. This is a study done by Mellis Group that proved our understanding that the acute hydrop start in the descemet membrane. When they tried to insert Bowman's layer in the midstroma, they had some cases that developed descemet tear, then result in acute hydrops. We need to grade acute hydrops so we can choose our treatment approaches. The published literature, some published literature tried to grade the acute hydrops. For grade 1, it's within 3 millimeter diameter, grade 2 between 3 to 5 millimeter diameter, and grade 3 larger than 5 millimeter diameter. We have two treatment approaches, either conventional medical treatment or surgical management. The conventional medical treatment can be bandage contact lens can be applied, cycloplegic hypertonic solution, along with topical steroid, and some give aqueous suppressants. The surgical management, these include gas or air tamponade, compression sutures, and venting incisions. Being proactive matters. Why? Because the resolution in conventional treatment may take several months, so longer duration, which increase the risk of developing corneal neovascularization from continuous irritation in the stroma, which can jeopardize outcome of any potential keratoplasty in future. We'll start with compression sutures. Why we would like to add to our treatment plan compression suture with, for example, gas or air tamponade? Because in cases with extensive descemet tear, the intracameral gas might escape through the gap into the intrastromal clefts, which will lead to failing to occlude the tear and delaying the resolution of edema. So in compression suture, we aim to reapproximate the displaced margins, prevent intrastromal passage of gas or air. So once the descemet membrane is opposed to the stroma, the endothelial cells will start to bump and will hasten the resolution of the edema. This technique I'm going to describe today, developed by Dr. Omar Qirat. We named it a continuous crisscross sutures for management of acute hydrops. The naming, this crisscross suture, it's used to close the defect in dental surgery, the pocket to close it by horizontal mattress sutures. So in this report, we aim to present the cases that we underwent this named approach. A total of 8 patients who presented with acute drop of vision and corneal opacity. 4 patients were male and the rest were female. The mean age was 29 years old. The youngest patient was 12 years old. The oldest was 58. A history of BKC was present in 10 patients. All patients reported that they had rubbed their eyes. Here I'm showing a video. So you can see the illustration on the left, your right side of the screen. First, we start with making limited conjunctivotomy, slightly posterior to the limbus. We make paracentesis to create inferior peripheral iridectomy. Then we close this paracentesis. And after that, we can inject intracameral either gas or air. We prefer gas, SF6. And after that, we dry the corneal surface. We make 8 corneal marks, like the illustration. And after that, with tin or proline and straight needle, we introduce the suture. We follow the numbers, the sequence, until we finish. Then we close the sutures. We titrate our tension, so we don't want to leave a loose suture in the next few days. We want it still tight, but helping to resolve this edema. Also, the same technique. We like to keep our knot superior. Dr. Omar Qirat, he doesn't like to bury the suture. I personally prefer to bury it because some patients, they rub their eyes and sometimes the contact lens may fall down. It's a full thickness suture. After the procedure, we keep the patient on contact lenses, like the way with keratoprosthesis, because still there is access to the anterior chamber. We don't want to risk infection. And we bring the patient for a shorter period for follow-up. After 2 months, we remove the sutures. We don't remove it earlier because we're afraid that the hydrops may recur again. So this table showed the results of our patients. Most of them are keratoconic. One case had post-refractive ectasia, and one patient has pellucid marginal degeneration. You can notice here that the duration of the complaints are very long. So medical therapy alone cannot solve this issue. So we need to go surgical in such cases. Most of our patients, their vision improved from hand motion at presentation and to relatively 20/50, 2100 after suture removal. Some patients had best spectacle corrected VA of 20/30. The last 2 cases had 20/80. Okay, the following slides will show the results of some of our patients. The first 2 pictures at the presentation. The second row, while the suture in. The third row after removal of the suture. The patient has limited corneal scar. This patient post-refractive ectasia. This is the patient, case number 4, keratoconic patient, has massive acute hydrops. The first row with the suture, the slit lamp photo with the suture in, anterior segment OCT on the second row with the suture in. and the second slit lamp photo before removal of suture. This is case number 6, also keratoconic patient at presentation while suture in and after removal of sutures. This is case number 7. The child came with massive acute hydrops. The first row at the presentation, the second row while sutures in, and the last row after suture removal. The conclusion of our case series that the modified compression suture resulted in fast resolution of corneal edema. Most of our cases, the edema cleared by the second week, and we noticed improvement since the day 1 post-op. It resulted in improvement in uncorrected visual acuity, contact lens fitting, and reduction of corneal neovascularization risk. We believed this technique can be employed in pediatric cases and other high-risk cases, including mentally challenged patients where keratoplasty is best postponed or avoided. Now we'll talk about keratoplasty for corneal hydrops. In acute stage, we usually don't prefer to perform keratoplasty, but some reported literature indicated they used their patient undergone PKP for certain indication like corneal perforation, unresolved edema, and extensive descalarization. What about LKP? Only few reports published in the literature with few patients. Most of them, they used pre-dysmatic DALK using manual dissection. And the last study by Lee et al., they performed it on 21 patients. In the first week after presentation, they did thermokeratoplasty along with anti-glaucoma medications and topical steroids. And in the second week, they performed manual LKP. They claim there is an improvement of vision with these techniques in the acute stage. After healing, we usually perform keratoplasty after healing. The classical teaching is penetrating keratoplasty due to the scar formation after healed hydrops. However, Tufts et al. Reported a higher likelihood of endothelial rejection following PKP in eyes with previous hydrops. The higher rejection rate was attributed to corneal neovascularization and severe allergic condition. The risk factors for graft rejection, as by Bazo et al. And Meyer et al., were longer duration of hydrops, allergic reaction, corneal neovascularization, presence of chronic inflammation, the younger the patient, larger trephination size, and poor clinical attendance or compliance. LKP in keratoconus after healed hydrops, the preferred technique is manual dissection. It results in less incidence of perforation compared to big bubble. The most preferred technique is the pre-dysmatic DALK or controlled air injection, layer by layer dissection until the pre-dysmatic layer, or it is safer to go more if you feel that still tissue or good scarring. We don't prefer to do big bubble technique because the pressure, the air or the gas injection might, the descent membrane may not bear the air bubble injection. However, in a recently published report, they showed success with a big bubble technique in cases who had hydrops previously. When to do the keratoplasty? Classically, between 4 to 6 months. What about the refractive outcome in penetrating keratoplasty after healed hydrops? In a study done by Bazo et al. Of 102 patients, where 31% of their patients they have history of resolved hydrops, they showed comparative refractive outcomes. Hendel et al. Also, they published a retrospective study of 211 eyes. They concluded that the visual outcome is as good as in the eyes with previous hydrops as without previous hydrops. regarding LKB in healed hydrops. Also, there are several studies published in the literature. Most of them, they use manual dissection or air injection to dissect layer by layer the stroma. Some of them, they do stromal hydration. The rate of perforation, they claimed, is very low. And the endothelial cell count after the surgery showed acceptable results. And the best corrected visual acuity post-operatively ranging between 2030 and 2050. So in conclusion, the post-operative complication in LKB are lower compared to PKB. The literature is scant regarding the outcomes of LKB following healed hydrops compared to PKB. So more studies are needed to address visual and refractive outcome and quality of vision in cases who underwent LKB following healed hydrops. This case was done 1 month ago. You can see the arrow, the tear in the decimate membrane preoperatively and after LKB. And also this another patient who had history of hydrops. You can see in the slit lamp, it's clear the tear in the decimate membrane who successfully had underwent LKB. And he reached the visual potential, his visual potential of 2030. Any question? Thank you. For me, I don't do big bubble. I do only manual dissection. Yeah. Any other question?
Bismillah ar-Rahman ar-Rahim. Thank you very much for this nice lecture. I think the message is delivered. Here at KKH, we see a lot of keratoplasties. Keratoplasties done 20 years ago, more than 20 years ago. And by this, we know that BKB is not a good surgery, period. Even for cases that had corneal scars because of hydrops, if those cases are allowed to heal, then they retain a good endothelial cell count, and lamellar keratoplasty can still be done. And there were cases on whom lamellar keratoplasty done after hydrops, and they have 20/20 vision, even if you can still see the scar, the residual scar. Strange enough, I had a case of bare decimate type 2 just by manual dissection after hydrops. And it's not a must. You don't need really to go very deep. The chance that you want to do a big bubble, I don't agree on this actually, because if you are planning a big bubble, you should plan it as BKB because the chance of conversion is always there. So the size of the graft is always gauged as a BKB in case they convert. In the manual dissection, we go for large grafts. And no doubt that large grafts in keratoconus or corneal ectasia are superior to small grafts. And actually, there are cases that we had to replace small grafts, either LKBs or BKBs. Bubble may perforate, not just because the decimate is weak, but because sometimes there are dense scar attached to the decimate. And so if the bubble is achieved in one area, it will propagate and tear the decimate. The conventional, classical teaching that hydropsies come to ER, give them sodium chloride drops, and then observe. This is potentially dangerous because if the hydropsies are large hydropsies, invariably, nearly all the patients end with scarring, but also with aggressive vascularization. And it's not unusual to see patients in the clinic who are marked as post-hydrop scar, but no one will think of doing keratoplasty on those patients. despite being young, with good potential, we know that with the vascularization, the keratoplasty BKB cannot succeed, and no one will think of doing a lamellar keratoplasty, because I think the majority will not think of doing lamellar keratoplasty to just mark the patient as post hydrops scar, which is not fair. And also there are significant, or let's say some percentage of those patients who are steroid responders. So you end up with someone with steroid responder with vessels and BKB. I don't know about this concept of doing BKB for an acute hydrops. I think it is against the conventional wisdom. I mean, we want to avoid penetrating keratoplasty. The understanding that, or the classical teaching that patients may do well after hydrops. So this is true in not a large number of patients, because some of them may end up with some flattening, with some improvement of vision, but it is not satisfactory to the physician or to the patient, because if a young patient with vision of 2100, you cannot do anything more to this patient, I don't think that this is satisfactory, even if the patient started with 22/400 or whatever. So the compression suture, you said that you don't bury the knot. Actually, I don't bury it. And when I did this technique first, the first run show the suture was inferior. I followed the diagram that I did, and the knot was inferior in the tear film and next to close to the lower lid margin. And I thought that this site is not okay for a knot, because it traps debris. So I changed and made the knot superiorly. And burying it is a bit difficult, because it's a very long continuous suture. You have to do a lot of traction on the sutures just to bury it. And if you want to remove it, if it is in the AC, fluid will follow it.
Sure.
So that's why I don't bury it. But thank you very much for your.
Thank you, Dr. Halah, for nice, concise lecture. I'm not cornea specialist, but I was wondering if you are going to take full thickness sutures.
It's full thickness.
We usually, how we thought full thickness sutures can lead to endophthalmitis because it's tracked to AC. So I'm not sure, did you find any patient who had any infection post this?
Only one case as a MK, but the reason that the patient didn't come for the follow-ups. Okay, we keep them on antibiotics, we keep them on contact lenses, we bring them earlier.
How frequent is the antibiotic? Like
QID,
the usual QID?
The regular QID until we remove the sutures.
Yes, regarding the full thickness suture, if you want to compress the suture, the cornea, it has to be full thickness. The risk of infection is always there, and risk of epithelial ingrowth, though we did not notice anything like this, is always there. Sometimes I apply fibrin glue over the suture to seal any possible leak. And we keep the patients on prophylactic antibiotics until all the sutures are removed, and close follow-up is needed. And there was one unfortunate incident. It's not included here. It was done by colleagues early in the approach. A patient of significant hydrops with leak, I guess. And it was suggested to do compression sutures. The patient had multiple interrupted sutures. And the problem with the interrupted sutures is that some of them may become loose, which is very likely. The continuous one is very tight, and I never come across any suture, any loosening of the end of the continuous suture. But the patient came to an anterior segment clinic with loose sutures that are full thickness. Unfortunately, the patient was not managed properly. the attending is no longer here and is not Saudi. I don't need to give names. But 2 days later, the patient developed endophthalmitis, Streptococcus pneumonia endophthalmitis, and he lost the eye. It could have been prevented. Loose suture should always be removed. Yet the patient was given a follow-up after a month with loose suture, and with someone who's supposed to be a professor in ophthalmology. Regarding the continuous suture, it doesn't only compress the suture, the squeeze the cornea, but also it reduces the curvature of the cornea. There was one patient who had compression sutures. He was a pellucid case, and a mega lens was easily fitted on his eye. So somewhere else they were suspecting infection, and they called me. I told them remove the sutures. So they removed the sutures, and when we tried to place a contact lens, the same mega contact lens, a new one, we could not because the cornea bulged. So if the cornea is allowed some time with this suture, it takes the shape. The curvature changes, and we can see it actually in the cases that we did.
Yeah, some of the cases we improved the contact lens fitting.
Yes. Regarding this model that you showed initially.
Yeah, I forgot to mention.
The 3D model? Yeah, this one, after doing the first case of compression suture with interrupted sutures, I was not really convinced with the way that the cornea was. So I thought of a way of how to compress the cornea, decrease the curvature of the cornea, and I had a silk suture that I took from Kekesh, and this piece of sponge. So I tried various combinations of continuous suture. The one to the right did actually the opposite. And the one to the left really compressed the suture, decreased the curvature of the sponge. And there was a puncture that I made on the other side, on the left side. This punch that I made also got approximated. So days later, I did the same on the patient's eye, what I did on the sponge. And it worked very well.
I have another question, if you allow me. Also, using sutures can induce new vascularization. So here, after hydrops, you don't want to have new vascularization in the cornea. When using the suture, did you notice that it had more new vascularization to the suture that you applied?
I did only 2 cases or 3 cases. I didn't notice any vascularization, but Dr. Umar, he did a lot more cases.
Regarding the vascularization, actually, the reason why we do the continuous suture is to prevent the vascularization. One patient I saw after being seen in ER, 1 month after being seen in ER, and when he came to the clinic, he was on the brink of having vessels. So I was really afraid that the patient will develop corneal vascularization. He was booked. He came to OR 2 weeks after seeing him in the clinic. And it's not shown here in the video, but there were vessels starting to grow, aggressive vessels from many clock hours invading the cornea. Doing the continuous suture, the compression, relieves helps in draining the edema from the cornea, reducing the inflammation, but also I do intrastromal and perilimbal Avastin injection, and then you may need to inject more in the next few days. So the vessels really regress. So this one continuous suture compared to the stromal edema, actually it helps in preventing the vessel rather than attracting vessels.
True, and also we keep them on anti-inflammatory and also Olopat, Elastat, for allergic therapy. Even if they have another cause to produce VGF and corneal vascularization, we try to treat. And also the compressions, continuous suture, not like the interrupted suture that might loosen, so induce more vascularization.
Usually you have trouble with the suture if the sutures get loose. any corneal suture, when it is loose, breaks the epithelium, and then there's a cascade of inflammation. But this continuous suture does not get loose if it is really tightened.
Thank you, Halah, for excellent presentation. A very important subject, especially for the resident who's working in emergency all the time. Actually, the treatment of acute hydrop mainly is a medical treatment. And if you manage well patient, they will end it with what we are doing, cross-linking. And it will help to stabilize the cornea. And most of the patients, if they treated well medically, they will end it with good vision outcome. As you know, the acute hydrops is a spectrum. It is mild to severe, which is the severe one, is usually happening with the connective tissue disease like Ehlers-Danlos and those. And those patients might benefit from medical and surgical treatment. So most of the patients, if you treat them well in the first 2 weeks, they will end it with the excellent outcome, and with the, you might even doesn't need LKB or BKB in the future, because vision, even with glasses, will be good, especially if it is away from the visual axis. The other thing, we tried all the BKB, LKB, all the things, and I think this is a good to have such facility. And most patients depend from patient to patient. You will not say this will be just only BKB or because of vascularization. Vascularization always indicates there is still active inflammation or active fluid collection. So this is, if you treat it well and resolve, the blood vessels even will resolve. Definitely with sometimes you need a fast injection and these things. So what I want to embrace here in this grand round for the medical, for the resident to start medical and doesn't stop it. Continue. Sometimes we continue for 3 months, for even more than that. Okay. And when you even sometimes I do LKB early if I see, and it will be, the outcome is extremely good. Okay. So the most important, how to manage in the first 1 or 2 weeks. And this will make the picture of the cornea and the outcome extremely good if you treat it well medically. Thank you again very much for this excellent presentation.
Thank you, Dr. Said. Any more questions? Okay.
Thank you, Halah, for sharing these techniques. I wanted to ask about the cases that you reviewed. Have you established what was the rate of cataract development with this full AC of air or gas or pupillary block and these kind of complications, or not?
I don't remember there are any cases of cataract.
Okay.
Yeah.
Thank you, Dr. Halah. Did you study the a comparison between this technique versus the conventional, comparing time and scar formation and vascularization?
You mean the interrupted suture or medical
yes,
therapy?
versus medical.
No,
I think
I started immediately with the continuous.
To have a solid
evidence, yeah.
Evidence, to have numbers for that, and
Yeah.
it's not difficult, but I think it's.
I only did one case, interrupted suture, because I couldn't perform the continuous. It's keep cutting with me. It was more huge acute hydrops. So but I used the same principle, interrupted. I put it vertical and horizontal, so it can close the gap.
And you said, how long did it take to resolve? 2 months?
From the first few days, you will notice like 50% reduction in the edema. Yes. From even first day. But by 2 weeks, It almost
Okay.
got. Yeah.
Versus we see
Actu-
some cases that are severe that come in the clinic after the R and still having the
Yeah, and
uh,
most of our cases, we didn't do it on the first day. They came to us maybe after 2 weeks and on medical therapy, and they didn't improve. And I remember the first patient I did, she broke in tears because somebody told her, "You don't have any hope, even in future."
I see.
Yeah,
I think it's interesting to make it as a study, so you'll have
yeah,
solid to
yeah.
present it.
It will be this one published soon, inshallah.
Um, Regarding the speed of recovery, we actually witness improvement of the edema intraoperatively in the OR. If you wait long enough, and for a couple of minutes, you start noticing the periphery clearing up. And this actually helps when performing the peripheral iridotomy. When you have the periphery becomes clearer, then you can perform it in a safer way.
And the sutures.
Yes.
And,
Yeah. It's not just the suture, it's also the technique of the suture covering most of the surface area of the break itself. The technique is like closing it up in a more efficient way than the interrupted.
Thank you very much. It is very informative for me, but I'm not anterior segment nor cornea, but I have always thinking of the box. I think the full thickness compression suture to resolve the hydrops has high risk to induce infection. Is there is a way to dehydrate the cornea on the table as anterior segment staff? Is there is a way to, instead of you suturing with anterior chamber gas?
Yeah, we actually started as a gas injection only.
Yeah, I mean, if I could dehydrate the cornea in the table, as mentioned by Dr. Fayrak, that some of these patients, after putting the suture, you could notice that the cornea edemas become less and less. Maybe if I take more than 10, 15 minutes, working to dehydrate it by, aspirating some of the aqueous from the anterior segment, from anterior chamber, keep the IUP in the range of maybe low IUP till the cornea is dehydrated, inject some air. I think there is a potential to help patient to have resolved hydrops without going through suturing.
Yeah. Actually, why we are removing the suture later, we want to induce scarring. We don't want the hydrops to recur. And there are some cases we did only gas injection. They have their hydrops recur again. So they only cleared for 2 weeks, the duration of the gas injection and the SF6, and after that they return. So most likely the reason of this is the frequent rubbing.
What type of gas you are using?
SF6.
And could you re-inject it again to prevent recurrence or no?
We can re-inject again.
I don't know, but if I have a hydrops, I will not accommodate or allow somebody to
If you
with
see
full
the patient
thickness.
doctor, you will do the procedure.
No, once you see endophthalmitis case, you will come to
hopefully
me.
you'll not see doctor.
You will see.
Yes, the option of just going simpler than doing the multiple punctures of a continuous suture or interrupted suture, just placing gas inside the eye. First, air will not be okay because air will next day will disappear, and the gas may absorb some of the stromal edema that, but again, it does not change the curvature of the cornea. And the cornea, when it gets edematous, for example, decompensated cornea, it swells posteriorly into the AC. But strange enough, after hydrops, even the anterior cornea bulges, and you can see the cornea, and there are some patients that the cornea was bulging through the lids. very aggressive, and you can see the indentations of the continuous suture on the shape of the cornea.
Yeah, true.
The suture was just diving, or see here. You can if you go back to the video, you will see the sutures biting through the cornea. The cornea is thrown into wrinkles and falls around the suture. What happens is that the suture does not change its place, but the cornea, the anterior curvature of the cornea subsides until the cornea is flatter. And strange enough, the cornea remains like this after removal of the suture, not an early removal, but a delayed removal. The risk of infection is always there, but with the continuous suture and with the cover of antibiotics, those patients, they do not leak. And if they are under cover of antibiotics with close observations, this doesn't mean that risk of infection is not there, but it's very low. That patient who got infected, it was an obvious mistake by someone who saw loose suture, see the wrinkles in the cornea. All these bulges disappear. The cornea goes back. The suture place does not change, but all these domes disappear in just few days, and the cornea keeps the same shape if you remove the sutures. So it becomes really flatter. So whether just gas injection causes the cornea to subside and becomes flatter, I think it needs a comparative study in the future with large number of this and that approach.
Still, I am in my position. Now the retina, when they put the gas, they ask the patient to put face down. I will put the gas, I will put face up.
Yeah, we do it. Fine.
And I will re-inject gas again. And I will give him some, maybe Diamox, anti-glaucoma treatment to reduce the IOP. I will try to dehydrate the cornea by any means. I could use sodium chloride drops, and I think gas will need to be studied very well.
This is, as I said, one may need to compare gas alone versus compression sutures alone versus compression sutures and gas alone and gas. And yes, we keep the patient supine position. The other thing is we don't like using carbonic anhydrase inhibitors because we want to encourage the. But of course, you need to because the AC gets 100% filling. We do surgical BI and we dilate the pupil to guard against iris pupillary block. And I did not come across any case of pupillary block. The BI is always difficult because when we elect to do this aggressive approach, it's not like doing it on a simple hydrops that is going to resolve uneventfully, hopefully to resolve uneventfully. But we know that those patients are going to develop significant corneal vascularization. It's not only the scar, the vessels. The vessels, once they develop, they never disappear. They may change into ghost vessels, but once you start tackling the cornea, cutting the cornea in keratoplasty, they reopen. So corneal vessels, unless they undergo apoptosis induced by, for example, by anti-VEGF medications, steroids alone, and the slow resolution of the hydrops, the vessels lose their caliber, but they become ghost vessels. They never disappear. And this is very common to see it in the clinic. If you look carefully, you see a lot of trees of ghost vessels.
بدياتك شغالين. Is there a way to use the anti-VEGF drops while the patient has acute hydrops when waiting for topical? As I know that there's some people trying to get some anti-VEGF drops that it may help. They inject it sometimes.
I think we can act on
superficial
superficial vessels. It will act more on superficial vessels, but I haven't tried before. I usually use aggressive steroids, and if the patient has allergy or vacancy, I use tacrolimus, Olopat. This is the treatment.
I think the anti-VEGF has a very important role, but the anti-VEGF injected into the vitreal cavity, the duration of the drug inside the vitreous cavity is not like injecting it in the subconjunctival space, a very active space. We don't know how long it lasts there, but definitely it has an effect. The drops are very questionable whether they are going to have any effect or anything. But the logical thing is that maybe to have a repeated subconjunctival injections. If the stromal edema is aggressive, then it's very doubtful that these medications will have any effect, because the stromal edema by itself is very irritating factor. It aggravates vessels and invites vessels. And sometimes actually I think the balance goes in favors the development of the vessels, even with the use of steroids and the use of anti-VEGF. Now, sodium chloride virtually has no effect.
No.
It's I don't know why it's made. Actually, I don't know why we write it to the patients.
What I understand about compressive suture is you are trying to compress the cornea and allow the DM to adhere to the cornea in addition to the gas. Do you think applying gas with almost 90% thickness suture might help in this, but at the same time avoiding perforation or penetrating the whole cornea and put the patient at potential risk of infection?
You know what? If you look at the OCT, if the patient is having acute hydrops that you want to consider compression sutures, it's not like stromal edema. Usually the stroma is full of aqueous pockets. These pockets are in continuity with the AC, with the aqueous. And sometimes it's not unusual to see a large defect in the posterior cornea. So even if you manage to put partial suture, it's not going to compress the cornea by any means. The compression is going to be partial. And these sutures are virtually full thickness, because the suture will pass through the aqueous caves or the buckets, and these buckets are in continuity with the AC. So you're not really like, it's not like passing a suture, for example, in lamellar or keratoplasty. That is not in the AC. But even in the stroma, it is really inside the eye. It is really inside the AC. And I think what happens is that the suture pushes the cornea posteriorly, and the gas pushes the cornea anteriorly and dries the cornea. So the fluid clears much faster than if you just put just gas inside the eye. And similar, if you just put sutures without putting gas inside the eye, it's not going to work.
Thank you very much, Dr. Halah, for this informative lecture. I have maybe one comment about the suture. I agree with Dr. Umar when he's talking about the hydrops. I just want to share one, like two patients I had with acute hydrops, but they were like in pellucid marginal degeneration. It was in the periphery. It wasn't in the center of the cornea. And those patients were leaking hydrops. So I think if there is a leaking hydrops, compressing suture is, and I think it's supposed to be our top option because it's already leaking. Usually the glue will not work. Contact lens might not work as well. And those two patients, I did for them partial thickness sutures. It wasn't full thickness. I did not like go 100% because it was in the periphery. It wasn't in the center of the cornea. And I used the interrupted with barred suture. And both patients, they ended up very well. One patient, I removed all the suture. The descent is intact. And even the vision is almost back as before the hydrops, because he used to have topography. So I think partial thickness compressing suture interrupted, it's a very useful if it is in the periphery, like in pellucid, especially those pellucid, they have very thin cornea at the periphery, so you don't want to have full thickness. And I have one question about the iridotomy. And by the way, those two patients, I did not inject any gas in the eye. I just compressing suture without gas, and they ended up, alhamdulillah, very well. My question about the peripheral iridotomy. some would do gas or gas plus compressing suture without performing peripheral iridotomy. I'm not sure if you any of your cases that you did not perform peripheral iridotomy.
No, I did follow in all cases prefer iridotomy because I don't want to pupillary block go. And I think at that time, no mannitol, no IV Diamox, I wouldn't risk it. Any question? Oh, Dr. Said.
Thank you again. I'm really totally agree with Dr. Misfir, what he mentioned regarding the treatment. And same time, what Umar reported is excellent, and it opened the gate to have more study and to compare it with others. But I'm pressing more and more in medical treatment. This is the key for success, okay? And even in the past, I used suture just only from outside, limbus to limbus, and inject gas, and it came with excellent result. So this is, if you did not try it, you can try it. Just only from outside, limbus to limbus, over the cornea, compression, and inject air from inside. So both will squeeze. And the use of steroid and sodium chloride is very important to dehydrate the cornea and to put it back. So my message is we can keep the gate open, do more cases and compare with medical treatment and see what's the final outcome.
Thank you. Okay, Dr. Mohanad.
Thank you, Dr. Halah, for this excellent presentation and this novel technique. I have one question. Did you have any case that the corneal edema recurred after removing the sutures? Another question.
Okay.
For the group, those who did thermokeratoplasty, did they describe how's the technique? Because they did it for early laminar keratoplasty, I believe.
Yes.
Yeah. Did they describe the exact technique?
I think it's in the paper. I don't remember the technique, but I think it's in their paper. Yeah. Regarding the recurrence, I had one patient who she didn't comply with the instruction. She rubbed her eyes. She had the recurrence while the suture in. So we went in again and we did the compression suture. Now she's doing great with the uncorrected visual acuity of 20/80.